currently we kind of have, we're in a box in a couple of different ways. In one way, we can learn things about one tumor, for example, breast cancer, and we can learn why some treatments work in breast cancer and why they don't work. But it's very hard for us to take a lesson that's a breast cancer lesson, then apply it to lung cancer, because we just don't have models for making those kinds of jumps. But if we look into the machinery of the tumor and see that, well, the reason the breast cancer is broken in this way is because this part of the machinery is disrupted, well, gosh, that's also disrupted in quite a similar way in lung cancer. So we can now take lessons from one tumor type and apply them more broadly to really accelerate the pace of drug development, to accelerate the types of clinical trials we do. And so, sure, lung cancer will have some specific things that are particular to it because it's the lung and we can only do certain things to the lung, but we can take these lessons across tumors and apply them. The gene, the epidermal growth factor receptor, has received a lot of attention in many different tumor types. But this is a gene it's overexpressed in some tumors, it's mutated in some tumors, it has certain types of mutations in some tumors, and in 2009, it's been very hard for us to put all that together and relate that broken machinery of the epidermal growth factor receptor to the therapies that we have. When we really, flood the system with information about how that gene is broken across many different tumors, I think we can then take lessons that we've learned in one tumor type about why does this drug work in this tumor, and look in a rational way across all tumors and say where are the places where the epidermal growth factor receptor therapies are likely to work. And there's many examples of that. The epidermal growth factor receptor is just the most mature and the one we know about, but there's many that we don't know about, and that's what's exciting about the Cancer Genome Atlas, is to be able to find those common broken genes so that we can target them and learn lessons in a very broad way. Mm-hmm. It's only in 1995 when we definitively learned that chemotherapy was beneficial for lung cancer patients in terms of helping with survival, and so we learned that relatively recently. Jump ahead, 15 years. Now when we see patients in clinic, we no longer are just asking, well, should we be giving chemotherapy for lung cancer patients? But we are starting to divide them into groups of patients based on their histories and based on a very limited amount of information in terms of their genetics. So my options for treating patients, 15 years ago, the option was, should I treat or not? Now I'm thinking, putting patients into groups and say, well, for this kind of patient, this is what I know, and this is the direction I'm going to go in. The tools that we have right now, so even that little bit of a jump has revolutionized our thinking. What's going to happen with the Cancer Genome Atlas is really to just totally revolutionize our approach to cancer patients, and really going from groups of patients. Now we're tailoring therapy to groups of patients, but we're looking forward to tailoring therapies to patients, and that's, I think, going to be the next step. We're not really there yet. We are doing some tailoring to groups of patients, but the individual patient tailoring of therapy, I think that's the kind of promise that we see from the Cancer Genome Atlas.